I'm going to try to go kind of fast through the first couple slides because they're more the general stuff, and then have some more time to kind of show you guys the splinting and ace wrapping and all that. So since that's usually more of our questions. So yeah, go over some general stuff. The post-op protocols, we get a lot of questions about the after surgery stuff, and then positioning, splinting, ace wrapping, and then a bunch of this stuff that Danny makes too. So he was off today, couldn't be here. I could be the lucky one. So yeah, our general goals, you guys are probably aware of our general goals, of course, is to prevent the loss of range of motion. So with burn patients, that's like the biggest key for all of therapy. So our general patients, we're walking them, we're doing stuff with them, working on functional stuff. But burns, like our biggest key is the stretching. Because the contraction process actually starts within 48 hours, the skin starts to tighten. And if you let that get tight, then everything else tightens up as well. The muscles, the tendons, everything. I mean, they'll actually shorten too if you don't keep that stretched out. So once that gets done and you like affect the tendons, everything underneath, you cannot get that motion back without surgery. So like we have a lot of times like adult patients where they get contracted like their feet down and stuff like that. That's something that really can't be stretched back out later once that Achilles shortens and things. So it's really important to start with the stretches right away and do them consistently every day. So that's always our big thing. So of course they come in here and they're very sick, they're in the ICU, but we really try to start from day one, teaching OT with at least some splinting, positioning, and some gentle stretching. So even if they're not medically stable for anything else, you will see us right away. We've been more and more involved now with the PICU too, I know, with getting more patients unfortunately there. But here's anything else. And then of course, just any movement in general and initiating mobility as soon as their medical status lets us. So. And then as patients progress, we can get a little bit more aggressive with them, try to get some more functional activities in. We start to incorporate more of the typical like PT, OT stuff you would think of, like the walking, the like doing some ADLs, feeding themselves, being involved with getting dressed, those kind of things. Because our ultimate goal is to get them back out in the community. So as far as mobilizing pediatric patients, we really can, even in the PICU, we really can get them up on day one if they don't have certain precautions. So if, for instance, if they're intubated or they have a femoral A-line, I think obviously they're just too unstable, we will hold off in that case. But even with a lot of the lines and Foley and a bunch of other stuff going on, we can at least sometimes sit them, stand them, do things like that. So we do try to get that fairly early, and it's going to depend on the protocols, and then we'll talk about those in a little bit too. I brought like some protocol sheets as well, so I can pass around if anybody wants to see them. I don't know if you guys have access to this stuff normally, so we'll go through that. But and then, so I guess this is more what we like look for with you guys to like work together as a team. So if we're going to be getting them up, or if the patient has orders for getting out of bed, we just want to secure the dressings as much as possible. We don't want to mess your dressings up, and you don't want us to mess your dressings up. So we usually ace wrap the legs. If they've got leg burns, even if they're not that bad, I'll usually put ace wraps on just to hold the dressings on. But if they have arm or like trunk especially, if you can get like a burn vest on them, or I know some people know how to make those little like shirts out of the the burn netting stuff. So if you think we might be coming by, that's always helpful for everybody. And then we try to work with you to set up a time, especially with some of the more difficult kids. So PICU especially, we will try to stop by like early in the morning and just find out like what the plan is as far as like what time you got to drink dressing, what time pain meds are coming on board. Because it is a painful thing for a lot of the kids too. The burns obviously are painful, so we will try to work with you guys with that. And it's hard for us because we're not on the floor. Being upstairs is a lot easier to like catch our adults when they're available, but sometimes with the kids it's a little harder. So some general stuff, mobility too. We do try to avoid adaptive equipment. So every other type of patient, we're equipped to handle a walker, a reacher, crutches, whatever it is. And we do get questions, not as much from you guys, I don't think, as sometimes the is it the PICU team? It's just the general doctors, not the burn doctors. They're like, why don't we get them a walker? Why don't we get them a wheelchair? In general, yeah, we try, especially with the kids, not to use any of that stuff because they get so used to it so quick, and then they compensate and they don't walk correctly. If you give them a walker, they're just hopping. Or I don't know if any of you remember Oscar. Yeah, they let him be in a wheelchair to go home. It's only for long distances, and then he came to burn camp and went and got a wheelchair like months later, totally healed. So like that, he had adopted that as like that's the new normal, and he would not get out of that wheelchair. So we really try to avoid it with the kids because They yeah, they adapt quickly. And then just encouragement about mobility, really we want that to come from everybody. Because if they hear from somebody like, oh, you're getting them up today, and then they go, oh, like they listen and they hear all that stuff. So a lot of times it's anxiety is our biggest limitation. Obviously pain is a factor, but anxiety is usually the biggest thing with the kids. Just like a few days in bed, like laying like this, they're just terrified to move in the beginning. And just like the thought, like, I'm gonna get up is like, what? It's so crazy to them. So the more they hear it from the whole team and trying to set up a plan, and then when they're good enough too, is having you guys get them up as well, like getting them up to the bathroom, like this is the new, this is the normal thing now. When you want to go to the bathroom, you're going to get out there and walk to the bathroom, get to the bedside mode. Because they're very adaptable too, like if they get on a schedule and they know that that's what's expected. But so yeah, anything you guys can do to encourage them. That's the same for adults too. If you ever get them, the more they hear it from like the whole team, they are more accepting. Because they're like, run, burn. How do you want me to move? But, so the burn protocols. I don't know if should like pass these around. I don't have it on a slide. Sorry, I just thought of this like on the way down. So if you guys want to take a look, it looks really complicated. So I'm going to try to like kind of sum it up. These are like what we have for as therapists for. There's like a bunch of copies of it. If you want. Yeah, sorry. This is like our official protocol from the doctors. So this is what we go by for mobility after surgery. Unfortunately, the residents don't always know this stuff or keep up on it. We try to educate them when they rotate in, but a lot of times this kind of gets lost in the shuffle to them because I think they're a little bit more focused on the OR and those kind of things. Kim and Lauren are great, and they know all this stuff. If you ever have any questions about getting somebody up after surgery, but obviously you're not going to remember all of this stuff, but it's more of a red flag for you guys to question in the future. So usually if they have allograft or cadaver skin, that's just a temporary covering, and like 99% of the time we're going to keep doing therapy the way we did before. We're not going to have really any, I think that got stuck in there. Nothing's probably going to change as far as mobility, stretches, all of that. We technically have to check with the doctors first, but I mean they always say just go ahead with the allograft. So if you see allo on your kiddos, that's usually fine. Xenograft is the pig skin. Are you guys all familiar with that? Okay. So it goes on wet, and then the first morning you guys will be cutting it down, hopefully getting a heat lamp on it if you can find one. That's a challenge sometimes, getting it to dry out. And then as soon as it's dry, we can resume therapy. So we don't have any restrictions, and so you guys wouldn't have any restrictions if you're getting them up after the xenograft is dry. It's just, it doesn't have the flexibility of normal skin. It's very, very tight. So if they xenograft like a large portion of the legs, the kid's not going to just pop up and walk, no matter what the residents think. We haven't had it in a while at least, but we used to get a lot with our adult patients. We had residents that would xenograph from here to here and here to here and be like, well, we left the knee out, but it just doesn't have that give still. So it can be quite a challenge. So, yeah, really though, they're allowed to like get up, walk, go to the bathroom, do anything like that with you guys. And then we're not usually in a rush about it, except like sometimes the doctors put the Xeno on if it's a small burn, and they're like, as soon as it's dry, we want therapy to walk them, and if they can walk, they can go home. So if you had one like that, we would ask that you like make it a priority to cut down the bandages and get that drying process started, because sometimes it takes hours, and if we're waiting after that, and then they're waiting on us to tell them if they're safe for discharge, it sometimes makes a difference. And then you guys know that'll just like gradually come off as that heals. It's the autograft that's always the big question, which is, of course, when it's their own skin. To sum it up, because this is what looks so confusing on here, it's basically whatever is autografted has to be elevated for 5 days. So that's our biggest thing. So if you can get them up onto a toilet or get them in the bathroom but keep that graft elevated the whole time, you can probably get away with it. Sometimes even like a foot or something like that, you can get them onto a commode, you just keep the foot propped up as they do it, but we just don't want that graft to be dependent. Once the graft is lowered, the blood's going to rush down there, and a lot of times you can actually get blood that comes between the graft itself and the wound bed. That's the hematomas that they have to drain, so if you do that, then it's not going to adhere and it's not going to heal correctly. So the more it's down, the more risk you have of blood getting in there between the graft and stuff. So elevation is the big thing with autograft. And we don't stretch it too. They're usually splinted. We don't stretch the autografted area for 5 days as well. But for instance, if it's just like their arm or their neck, though, we can still come and get them up. The first day we just have their splint on and try to keep their arm up. Yeah. trunk, they usually have us wait till day 3, and then legs, it's usually day 5 for like walking around or anything. But I know sometimes for the kiddos, it's kind of hard to convince them to get on a bedpan or do something like that. So if you have to get them onto a commode, just make sure you keep the graft elevated all the time. So, and if you guys ever have any questions, because obviously you're not going to remember all of this, but like I said, sometimes the residents just don't update the orders after, and we're not around as much to like tell you guys. So we just want to prevent any graft loss if possible. So, like I said, if you ever have any questions, just call and try to get Kim or Lauren, and they're familiar with all this stuff and could clarify anything for sure. So one of the big things we do is also, with the stretching, we do anti-deformity positioning is what we're looking for. The burn skin tightens as it heals as part of the normal healing process, but it kind of contracts from the edges and pulls in. So wherever you've got the burn, it's going to pull in. So we look at that. So we can do a ton of work with them. We can stretch them all out, but if we get them all stretched and perfect and then they curl up into a ball for the next like 12 hours, we're kind of losing all of that. So we try to do some positioning stuff with them, and I think it is harder definitely with the kids than the adults. So we understand it's not always going to be perfect, but so we want to prevent the contractures without like compromising function. So we kind of base it on the kids, how alert they are, everything like that. So I'm just going to go to the next slide. So these are some of the examples here. You can see it. The first example in each one is what we don't want for positioning. So the contractures are really most aggressive on like your flexor surfaces, they call it. So like inside the elbow, the front of the neck. You guys have all seen that, I'm sure. The back of the knee. Those areas are the really like the aggressive contracture areas that we really have to fight against all the time. So for instance, like the back of when it's like the front of the neck here, that's why we do the no pillows thing. Have you guys all seen that? We try to put a sign in the room saying no pillows, and yeah, or a pediatric mattress if it comes to that, yeah, when it's real bad. But so just reinforcing with you guys, there should be a sign up all the time. But sometimes they move rooms, sometimes stuff gets thrown out. So if you guys have a patient that has a big burn here and you see him like on some pillows like this, take the pillows out if you can, or send us in to be the bad guys, that's fine too. But just want everybody on the same page with that. The second one there, you might see that for the airplane sling. So if the patient's like burned in here, that's really bad too. You almost can get stuck to it. It's like the two surfaces can get almost stuck together if you like keep it down all the time. So those are the cases if they're burned in the axilla, they might have the airplane slings ordered. Danny actually just revised, when he has a student now, they like worked on a new handout for that too that should make it a little bit clearer. Because I know before you had like the little stick figure drawings. You guys have seen that up and around, and a lot of people are like, I don't know what that means. So they actually got some photographs and like how to put the pillows back there and everything. So that should be, you should start seeing that soon. They're just going to the print shop now, so that might make it a little more clear. But and then the other issue, so for like my side of it is the PT. Kids especially, like they want to be curled up in a ball, and like the really little ones, you guys do that for comfort. If they don't have leg burns, obviously that's fine. But if they're burnt back here, we really can't do that. We really got to keep that leg straight all the time. So if they need to be elevated, we put a pillow there, but put it down towards the end and keep the leg straight. And if it gets to be a real issue, they'll make like a knee gutter splint to hold it straight all the time. And then of course like the foot drop thing too. That's why they might have like a foot splint. Gravity is just pulling the foot down all the time to that position. We want to make sure it stays functional. So like along with all that stuff, splints are, oh yeah, good. I'm glad there's a picture in there. Some of these are Danny's slides too, so I'm like, well. Splints when they're post-op are like a doctor ordered thing. So that 5 days, they have to have a splint on all the time except for dressings or for skin checks, and it's in there as an order. The rest of the time is really just a tool that we use. As therapists, as nurses, you guys can too. The schedule is really flexible, and it's based just on what patients will do and how tight they're getting. So if it's a patient that absolutely refuses to stretch or they're just not doing anything on their own, we might splint them during the day just to keep that functional position. But if it's somebody that's like compliant, is doing stuff, we would want them off during the day to like encourage the patient to like run around, move, do everything for themselves. So really besides that, like 5 days after surgery, it is like a flexible schedule. So if you guys notice like someone's starting to do a lot better and you want to change it up, just let us know. And we usually try to put signs up with this as well. Sometimes they're not updated. Same thing, but like just like the no pillow sign, we try to put a sign up by the patient's head of bed. this says like what the wear schedule should be for that. So, because sometimes you might see an order for it, sometimes you might not, depending on who's there that day. So yeah, that's the airplane sling. So, it's not something too often. I don't. Mariah had one at some point, but. Oh, okay.
Yeah, there was a girl in East that had them ordered. I said, what are airplane slings? And everybody was like, I have no idea.
Oh yeah, the burn was
Okay.
We used to see them before.
I mean, you can kind of do the same thing with pillows, to an
Yeah, I
extent, but
think
it just
it's
doesn't
more,
hold them.
I don't think they do that with a lot of the younger ones because they
Sometimes they
stay
assume
still,
they
and
won't,
then they
yeah.
might think it's a swing.
I felt like they always used to come with the trapeze bit. Because we used to always tie them.
Yeah,
Oh.
they,
So I don't know
Yeah,
if there was just
the
like a
time
safety
anymore.
thing, probably.
Yeah.
Little one.
But, I mean, we do occasionally still try to use it for the kids. It's that thing where you had, Mariah had like a day or two put a stop in the PICU, but just to like hold
when
it
they're
out.
sedated,
Yeah,
but when they're awake.
it's hard to,
So we use
yeah.
pillows on
Yeah, you
the-
can't even keep the
Yeah.
rotors spin.
Yeah, we don't, it's more of a PI thing.
Yeah, so it's something that sometimes is on for just the nighttime, sometimes it's on for like day and night depending. But, yeah, if you guys ever do see orders, I mean, you can always ask us if it's something we need to. They were trying to order for one of the kids recently that was burned like on top of her shoulder. We were like, that's not the issue. We actually just want to, if she was burned in here, we need to stretch that out, but she's on top, so we got that fixed, I think, eventually. But I heard one weekend that was an issue, so. But yeah, if you don't see it, and you don't, it's like, say it's a Saturday and you can't find one of us and stuff, then just put the pillows under too, so. The idea is you want to keep like as much of a stretch as possible, but you don't want to have the arm all the way up. If you get up too much above 90, you start to get like numbness and tingling in there. It starts to compromise like the brachial plexus and thoracic outlet and all that stuff, so they can lose feeling. So we actually just want to be like at 90, not above. And then not too far out like this either, if it's too much of a stretch.
Just axillary.
So it's just the burn.
Just
underneath.
axillary.
Yeah, just for axillary burns usually. Or I mean, if it's like from like here to here, you know, a real bad one too, like they're down, they might do it, but because all that skin's connected. Stretches, but so splint donning. So I wanted to show you guys a little bit. Are you guys familiar with the? I mean, you know all the splints, I guess, but okay. Just we do sometimes still get questions about this, and I don't know if any of you guys are newer. So whenever you're doing the arm splint, I mean, it's mostly a gutter, so it really can just easily get displaced. And if you do that, you know, they bubble out that spot for the elbow, but if this gets in the wrong spot, you're getting pressure on the elbow, you're setting yourself up at risk for a pressure sore. So there's really not much of a good anchor point. Your only anchor point is the wrist. So that's what you really want to like start with and secure that. If you can get that secure, that's going to help keep it in place a little bit better. So I know I might actually do this on somebody else. Do you mind if? Be a good patient, just hold it and not scream and kick. Like,
Come on.
Make it look real, come on, come on.
So this is usually where we would want to like anchor first and get that. You want the wrist to actually be in a slight bit of extension.
And we
then
should
from
take
there
our
you
watch
can-
off first, yeah.
Well, yeah. And then you try to go here, get the fingers secure by themselves, as well as if they have like hand grasp, you don't actually want to get the thumb and stuff too. Make sure that the. And then you can always like kind of go around and make a little bit more of a mitt. I think Danny makes like kind of like a figure 8 around here to really get that tight. And then from there you can just go up the arm. But no matter how perfectly you do this stuff, if the patient's moving around a lot, it's going to get out of place. So it's something just to keep an eye out for, because it is a risk for pressure sore if the splint is in the wrong spot. So from time to time, you may have to fix it up. There you go. Well, and we've had some tough ones lately too. I mean, there's been kids that like they don't care, they put the splints on, they're fine. They actually kind of like them because they feel like it's like protecting them. So they actually prefer to be in their splints. So we take them off, they freak out. But our ones lately, I know, have been more
Challenging.
Yeah.
That's a good word, challenging.
Definitely. Leg thing, he didn't actually have any up there pre-made that have the platform, but there are different splints they can make. So if you have like a kid, I know you guys are probably more familiar with the ones with that little platform that comes on the bottom. But if you have a kid that can't stay on their back or they are moving around a little bit more, they can make some other types like this as well. And he'll kind of like bubble out here so there's no pressure on the heel and cushion it. But this is the only one that was down there. But same thing with the foot splint, you just want to like really anchor. This is your anchor point too. It's just like right around the ankle. All this can easily slide off and on. And once the foot slides down, then all the pressure is like right on the ball of the foot. That's like your highest. I think probably out of all of our burn patients, that's the highest risk for pressure sores over that metatarsal head, because they kind of slide down and they turn their foot in. So just something to keep an eye out for if you see them doing a lot of that. I know it's a pain, you guys are busy, but try to get them like readjust to get the foot back up where it's supposed to be and secure it. And that's why we want to secure really good too. I know sometimes people just like leave kids and adults like just laying and like just put the foot splint like on there but not secure, but then the foot tends to drop down. It's a lot of pressure. So if you're going to put it on, it's best to at least secure the foot area so it doesn't drop out of there. And then Curlix is your friend. Use a lot of Curlix. It's not that expensive. You know, the more you get on there and secure it really well, it's going to be less likely to migrate. So with that, pressure sore prevention. So a lot of our stuff kind of can put you at risk for a pressure sore, but I know Danny makes a lot of stuff here that helps prevent pressure sores. Get all this stuff out of here. All right. So you won't see much of this obviously on the floor, but for the ICU ones, so a lot of times their airway, they secure it with the band netting, and they'll do that right in the beginning. They make it really tight because obviously you've got to protect the airway, is the biggest thing. But our burn patients tend to really swell up. The big burns in the beginning, when they get the fluid resuscitation, their faces swell and it gets really tight. So what was happening was this was kind of cutting in on the corners of the mouth with a lot of patients. So we've got these. If you guys don't have them down there, does anyone work in the PICU right now? Okay. I know they've had them down there before, so I know Danny or the other OTs, if they come to do an eval, they will bring them, but sometimes respiratory is familiar with them, because they'll come, respiratory therapists I don't know will come to the hydro room and be like, hey, I need some of those. But they just slide in here. The idea of these is actually to protect more of the corners of the mouth. They call them cheek protectors, but the idea is really to protect this area more, so they really actually should be pretty close to the mouth. Not like way out here. Not really doing much of anything. You always want to have two. If you have one and that's pulling, it's actually going to make the other side worse. So you want to make sure you always have it like balanced and stuff. And sometimes they might like slide out of place a little bit. We used to make ear protectors, but those have kind of gone away now because we use the bridles, usually not the bayonet anymore. But there is like an ear protector thing that would sit over here too. If you ever have somebody that the Doppler for some reason can't be bridled and they have the bayonet across, that helps kind of protect. Because otherwise it was like running across the top of the ear and kind of messing up that cartilage there. And then the occipit's always high risk for pressure sores. So got these. You guys seen these before? Okay. Especially for patients, if you don't want like a pillow back there, that's a good way to compromise. It helps protect that for sure. And this is a relatively new one. Patients tend to turn their head towards the side of the vent. They keep it that way, and if they've got any burns around here, even if they don't get burned, they sometimes get a little stuck one way or the other. So making these. So this actually usually works together. So it helps keep them from turning the head too much. The kids just being a different size, we've had a couple of times where like the head almost sunk too much into it and was like rubbing on their ears. Adults, that doesn't seem to happen, but I know we had to before. So like with Mariah's, like we cut like a chunk out on each side so there was nothing actually touching her ear. So it took the pressure off and it seemed to like help a little bit. But so just so you know, this stuff's out there. So if you do have a patient that you're noticing problems with, they'll probably be making it for them anyway, but you guys can know to ask.
Hey, Bridget,
Yeah.
can I just ask you about the bridles? Since you guys have a ton of experience with the NG and feeding tube bridles, have you ever had any serious complications related to bridle usage? Because I'm always trying to encourage it on the pediatric floor, but some people feel like, you know, I think they get it confused with the old time bridles where we used to suture to the nose. And these are, I'm just wondering if you had any complications.
Nothing I'm aware of with any of the adults. You may want to double check with Kim or Lauren because they might, they're going to be the ones they would go to about the bridle, but I've never heard of anything.
Okay, great.
And most of our adults, they do get the bridle because a lot of them are just confused and they'll pull at it too. So, yeah, I noticed the kids don't seem to have it as much. I didn't know what the reasoning was for that. Or
I think we're
Yeah.
just not used to them.
Yeah, I was just
I
gonna say,
think they
they're
work really,
comfort
really
level.
well, and I
Yeah.
think once you see them put in, you're not as freaked out. But I think there is confusion with the old time, putting the suture in the nose, which was pretty inhumane.
Yeah, and if they pull, yeah. But yeah, double check with Kim or Lauren could tell you if they would know if there's like a record of anything ever happening, but.
Thank you.
Yeah. We've heard about, but, so I'm trying to think. Oh, and then, I mean, the bottom, this is like an actual picture from our ICU when we came in one morning, so just please, like I said, I know it gets like really busy, but if a patient splint gets off like that, just please take a couple of minutes to fix it so they don't get pressure sores, because this guy did have one. He actually had one before, you can't, it's kind of too washed out here, but there's actually a dark spot there because this had been bubbled out to like help with that, and then, yeah, plus he's jammed up against the bottom of the bed, this was like digging in, it's just, it's not good, so. Do you guys have any questions about like the splinting or positioning before I get too carried away? Does it all kind of make sense? So, yeah, just anywhere, just think about like where their burns are, and that's the part that's kind of tight, and that's the part you want to keep on stretch all the time. So, all right, then I'll go over A-strapping here real quick. And you guys are probably pretty familiar with this. Anytime, like if they have leg burns, when they stand up, the fluid shifts and all rushes down there. They don't have the support of the skin anymore, so they get a lot of extra pain. I know sometimes the kids don't really articulate it very well, but this is like a big thing with all of our adults. You know, if they have any kind of burn on the leg, they'll tell you it's a lot more painful when they lower their feet down. They get a lot of throbbing and stuff. So we use the A-straps to try to help compensate for that skin, keep some of that swelling down, and help with pain too. So, and it tends to be the lower in the body it is, the worse it is. So they can have like a burn like this on their thigh and they might be okay, but sometimes even like a small foot burn and they just can't handle it. And I have adults the same as kids screaming and throwing their feet back up in the, you know, in the bed, like they won't lower and they like hold them up in the air. They put them up on a walker as they're like trying to walk because they don't want to lower the legs. So it's a real thing. But so yeah, we use the A-straps to try to help compensate. With the A-strapping, if they have an autograft on their leg, you must A-strap all the time. If they're just getting up real quick to the bathroom or something, if their legs are going to be down, they've got to have the A-straps on. If it's just like a burn, you have some leeway with it. You don't necessarily have to do it, but I try to err on the side of doing it because if anything, it's just going to help some with the pain and swelling. It's not going to hurt anything.
Does it matter how long the A-strap stays on?
Yeah, so we talked to Dr. Smith about that. Really, we wouldn't want it on overnight or anything like that. He said he'd rather err on the side of having it on too long than not enough. So if you have a patient that just suddenly has to go to the bathroom a lot of the time and you don't have any warning, sometimes, you know, just putting the A-strap on, leaving it on for several hours, that way they're ready to go whenever. The only exceptions would be, like, almost all the time they've got bandages on their legs, too. And you just put the A-strap on over top, it can be on, no big deal. But when they're, like, open to air and they need A-strapping still, that gets a little more questionable, because when they're up, they're going to bleed just a little usually, or ooze a little, and then it could get stuck. So we'll do a layer of wetting veil between the A-strap and the leg, but even that I wouldn't want to leave on more than an hour, probably.
So even if their autograft is healed,
Mm-hmm.
they still have to have ACE
Yeah.
on.
Usually for at least like a couple of weeks after the autografting, they want it on. Like they send them home with it.
Right.
I always tell them to follow up when they come back for their follow-up visit in the clinic to ask, hey, do I still need to use the A-straps? But because everybody wants like the timeline, when do I stop with them? But it's hard to really say. It's when they're all the way healed.
That with the thighs too?
Mm-hmm. Yeah. But even some of our ones that have gone to rehab and it's like weeks past grafting, like we're like, okay, we'll leave them off and like we'll see them, but they're like, the legs are purple and like swollen around the ankles, you know, from walking. And they're not going to lose a graft at that point. It's going to stay healed, but it still is kind of, it's more painful for them and they get a lot of swelling. So it's usually a while after grafting they need it. But yeah, even if it's like a thigh graft, they still want us to like graft the whole leg to keep the swelling out of there. Dr. Smith is very adamant about A-strap, so it's come up in our like M&M meetings and stuff. I think it's a combination of factors. A lot of times when patients go home and lose a graft, it's usually other things with our adults like smoking or poor nutrition, things like that. But a lot of times it's the, A-strapping gets the blame. So we really try to push that with all of them. We have handouts. I don't know if you guys have ever seen, we try to give them because we have like color, I guess I don't have one down here, with like color pictures of how to put the A-straps on. There's instructions on the other side. I don't know if there's some way we can make those more available for you guys, because we're, like, our nurses.
Terrible.
The figure eights you
Oh.
have.
Scratch it, I
I
make
can
it
open
it's
their
right.
class.
Like, I'm
Without
it's on.
me.
Okay, well, I will tell you, the figure eight is the ideal thing, because it's gonna stay in
Yeah.
place better, but if you can just put it on, yeah, I actually have ace wraps, because that's what I always, yeah. As long as you get it on there, have some compression, like, it'll help, so. I wouldn't do the discharge stitching like that, but if you gotta get someone in the bathroom, get someone in the bathroom quick, just wrap it up, that's fine, so. But yeah, I always bring stuff so that, we can kind of go over that, because everybody's like, I don't know,
I
how
put
to
it on the wrong side.
so.
I do too, I have to turn the
I
very
started-
left
I
piece
started
backwards.
on-
So I get it right the second time, because I'm
Yeah.
wrong the first time.
Oh, no, I always get it wrong. Remember?
So I don't know if somebody can use as a volunteer, and then everybody can kind of like
I have
stand around
pants
real quick
on.
and see it. I'll just wrap over your shoe or your pants or anything, doesn't matter. Would you be able to get it on here?
Yeah, can she, say, sit on the table, put her foot on the chair, and then you could...
Oh.
I mean,
Did not.
You're not gonna break, is it?
You don't wait.
It's not for you.
So it won't look as perfectly neat over a shoe, obviously, but we always start with a small one. Kids, unfortunately, we don't seem to have like the little ace wraps. 9C, I think, gets them, or you might be able to get them from SPD if you have somebody like call down there. Because if you have like a really little one, it would help to have like the smaller ace wrap to get around that ankle better. But all right, so we start. Actually, should I turn this so you can, so you guys can all see this?
Start Velcro
Okay.
up?
Yep.
you say? Okay.
So hopefully the roll is like this when you get it.
Okay.
And then we start Velcro up. Come around, we just leave the toes out, and then the Velcro should like, yeah, that'll make like your anchor point there, so.
That
yeah.
totally makes sense.
And then we start right from there, so like I'm gonna angle up, come around. The ankle's a little different, so I'm gonna kind of go up, and then you always wanna try to catch everything. You don't wanna leave the heel out, because if you're putting pressure here, you're gonna push the fluid right to the heel. So you wanna try to keep everything covered. And then I'll start with a figure eight from there. So I'm going to angle it up, bring it around the back, angle it back down, bring it around the back, angle it up. And I'm usually just getting like a little bit of a pull as I come around. So I'm getting like a little bit of pressure on there. And hopefully, then the Velcro will just stick and go down.
So you go up and then back down and up.
Yeah, I'll keep going with this if you don't mind, so you guys can see. But and we just try to say stretch it out about halfway. So you don't want to just lay it on like this. It's not really doing anything. It shouldn't be on like this tight, like really wrapping it up. They're going to lose circulation. So just give it a little bit of pull each time as you come around to put some of that compression on there. And then yeah, I usually just overlap and same thing, Velcro up. And then it sticks to itself, so it stays in place. And then I angle up, angle down, angle up.
So easy.
Yeah.
It looks
She's probably done it before.
So, and then hopefully, yeah, the Velcro will just end over itself, but, and you can do the whole leg if need be, or just the thing, but yeah, even if they have like a thigh graft, like we still wrap from here up, because the point isn't just to like put pressure on the graft, it's to keep swelling out the leg. So we do want to wrap the whole leg up. And then always take time, don't try to put the graft on like this. It's not gonna, yeah, you're not gonna be able to get it on correctly, you're not gonna be able to get the right pressure, so always take the time to like stop and roll it up before you do it, so. But yeah, we have handouts up,
backwards.
yeah, I always.
Go backwards then?
Yeah. I don't know, I always look at it like I just see this. I like lay it out and then I just roll into it, so I don't know.
Velcro up is like,
Because sometimes the rolls are different depending on the brand we get.
that's you.
You're right. Oh, yeah, you're right.
But I don't know if there's any place we could leave handouts for you guys if you ever have to do like discharge teaching on a weekend and we're not here, or I don't know if maybe that's something we could put on the portal that you guys could access. Like I think it's under our rehab stuff on the portal
I'm sure it
for our
is.
therapists, but I mean, I know sometimes, especially with peds, we're not as in touch with you guys as we are with the adults, so, you know, they can get orders on a
if
weekend or
you
evening
have
when we're not
links or
around.
something, I can put them in the video or on the course page so that when
Okay,
people are watching it, they can access it easy if they need to.
okay. That'll work. Cool. Do you have any other questions about the ACE wrapping? Like I said, as long as you wrap everything, you are still getting that compression. You are going to help protect the graft. So don't not wrap just because you're not sure about how to do it. So I've seen that happen with a couple of our nurses upstairs. Like, well, I didn't know how, so I didn't do it. Just at least get some compression on there. You'll at least be doing some benefit in protecting that graft. So, and then you can work on the pattern later. I think that's most of the big stuff. The scar stuff, like we don't really do much of this stuff, so I just threw it in here at the end because we get a lot of questions about that. The pressure garments are really something that happens down at rehab or in outpatient. Let's skip this one for a second. Anyway. Actual like pressure garments, you can't fit a patient for those until all the swelling is out of there and the graft is completely healed. Everything's 100% healed. You wouldn't want to like be pulling that on over not firm skin, and if there's any swelling when you take the measurements, when the garment comes back and the swelling goes down, it's not going to be doing the correct compression. It'll be like too loose, so you have to wait till all the swelling's out. So we just don't have patients in the hospital anymore that are at that phase. Like years and years ago, like the stay was a lot longer, and sometimes they were getting fitted for this stuff, but that was like before my time. But at this point now, they're pretty much always gone. So when patients ask about it, it's something that they'll follow up with in the clinic later. Usually they'll come back and see Kim and Lauren in a week, and then like down the road from that, they'll go to South Armenia, and they usually can get fitted for at least one set of garments that's covered. I hope they'll be wearing those. If for some reason someone's like really healed in one area, they do have a couple things they can use. It's possible you'd occasionally see this stuff, but they call them interim pressure garments. Like if say they just had a hand graft and that's healed, but they had some other surgery, so they're still here, they may have like a glove on for part of the day. That's going to help start putting a little bit of compression on there. I don't think we've had any kids with this. Okay. The big thing with the isotoner gloves, though, seams always go out. So you don't want to actually, because you're.
I just remember you would always say like smell.
Yeah, because otherwise these like seams will like put pressure on like certain areas. So you actually want, so it'll look kind of wrong, but yeah. And I mean, this I don't think we've ever done any of the kids, but this is just like tuba grip, and it can put a little bit of
I think
compression on there.
Yeah, he had everything.
Yeah, he had everything.
Yeah, he was here. He was here a long time. Okay. Yeah.
He had a suit and everything.
Yeah.
So the big thing with this, they probably have like a leaning on or off schedule with it.
What's his name? What was our rehab burn?
He had a full mask.
Oh yeah.
Not just him. My boy at 12. Lost in the couple limbs.
The one that was stuck like this.
He had a lot of those things.
Yeah. So occasionally, the big thing with this stuff though, is just make sure there aren't any wrinkles in it. It's like evenly smoothed out. If it gets bunched up, it's putting too much pressure in one spot. So you just want to make sure there's no wrinkles. And there should be a sign with like a wearing schedule for it, because it's usually they're going to gradually, they'll have it on for an hour and then off for an hour, on for 2 hours, off for 2 hours. You don't want to just put it on and leave it on. And then you could actually have both on together where you have, this too, but I think you actually put this on the outside. With the other one.
Yeah.
Shouldn't be on the recording one since this is not mine. But yeah, you get the idea.
Yeah, no.
But if it's something like this, I mean, this is out of the ordinary, so I mean, whoever like issues as the patient should be talking to you guys and kind of filling you in and putting a sign up for information and stuff. We know you're not going to know all of this stuff, so. Other than that, there's just like specialty. Okay, airplane slings we kind of already talked about. The pressure sore prevention. Okay. I guess mouth openers the only thing. And then these. This, now that we have occasionally more PICU patients, Danny can make a lot of crazy stuff with split materials. So, like we've had patients that are graft and they can't push their PCA, so you actually can like slide the button in there and you just have to like bump it, or they can push it with their foot. We actually did use it on somebody pretty recently. He actually can make like a splint thing that hooks over the bottom of the bed so they can push down with their foot and like pull that off. I know it's not much that happens to the kids, but he's made other things too. With like it's, I think it's some of them. Oh, one for the call button.
Yes.
They could just do like the channel up and down.
Keep pressing when they go in the room.
Yeah, like he made one for a lady that had like finger amputations. To make like just for the channels up and down, like she would be able to just change the channel to there. So, have you guys ever had like a weird problem?
Yeah.
Like he's very inventive and ask him, yeah.
Yeah.
I never have to work here again.
And then there's mouth openers. Okay, so this one is like this new thing. I'm not going to demonstrate because this is not mine, but This is actually part of like a game, I guess. Have you guys seen it? It was like on Ellen or something. You're like supposed to put
Oh,
this
yeah,
in,
yeah.
and then it
Oh,
stretches your
Robin
butt out
was
like this,
just
and you have to, you try to
doing
say
her
things.
granddaughter's
and it's
talking
fun.
about this game.
that
Yeah.
game, yeah. Okay.
So it's something he actually, all different sizes, and he's been trying to do that. This is something he would just use probably during treatment to like give him a stretch for a little while. This is kind of nice because the old ones just stretched like this, usually just straight across. But this kind of does more of an open the mouth, like all over kind of thing, so you may see this stuff occasionally. And then have you guys seen Needs?
We had that.
She might have
You
Needs.
have that thing.
Yeah, my mom's giving it to me.
I'll show you.
He'll with that.
Yeah.
So the idea with this is like, you know, you just pinch it closed and you kind of get it in the mouth, and then once it's in there, you just turn the screw one way and it will like slowly open and put a little bit of a stretch. So, the mouth should fit in like right here. I don't want to demonstrate, but like there should be right here, so, yeah. And so you just make it really small, and then you can get it in the mouth, and then you expand from there, so. If they have that, it's probably like in a styrofoam cup taped to the wall with like an instruction thing by it, but. So, probably other specialty things I'm forgetting. Oh, well this thing, if they have xenograph on the back of their leg and you have to let it dry out for, you have to let air get to it, so we'll make these, and you can actually even just like cut out a hole too, so nothing's touching the back of that wet xenograft. Let it dry. There's like arm ones too, they're just like a square, but you can attach it to an IV pole. So if you have a xenografted patient and you need help getting them dry. Although kids do a little bit better with laying on their stomachs too. Some of our adults, it's just not gonna happen. So we have to come up with some different things, but, I feel like that was a lot of stuff, but do you guys have questions? Like what comes up for you guys as far as, okay.
That ace rap.
That
Walk away today with knowledge.